Hello, and I'm Deborah Estrin,
I'm JP Pollak.
and we'll be doing this a little bit tag teaming. And just before we get started, how many of you are on the clinical side and on the tech side? I guess you can raise your hand twice. And one more thing, students? Okay, and now iPhones, Androids, feature phones?
Windows.
Got it. JP wanted to add the question, how many of you know what an API is? But I decided that was rude. So we won't ask that question. Don't raise your hand. So we have tried to set the stage on what we mean by consumer-driven health and small data. And then we thought we were having a workshop with a room with tables, and people configured it a little bit differently. So we're going to have some discussion and then amongst yourself in small groups. So if you're a little island sitting not next to anybody, you might want to scoot nearer to somebody else for that part of the session, but that's probably 25 minutes away or so. Please interrupt with questions. If we feel we're getting to it, we'll just defer you to later. I'm at Cornell Tech, the new campus of Cornell University that is temporarily growing in the Google building in Chelsea. We're not inside Google, but they're very nice landlords because they don't charge us any rent. And we have great shared space there. We're at about 150 master's students, 3 or 4 different programs, and a very new one that is specifically in health tech. And of course, we're under 20 faculty at this point across digital operations research and management, and with PhD students and all those sorts of programs growing. And in less than 2.5 years, we'll be moving to Roosevelt Island, where we have a new campus being built. I put the advertisement at the beginning since I knew I wouldn't get to it. So I like to put this in context, and particularly having listened at least to the second part of the panel that I'm sure some of you heard before lunch. There's so much really important work happening in what we think of as big data science, where you have large amounts of data, not large enough and not together enough, but we're moving there, across EHRs, claims data, patient sites, all sorts of omics data. And from big data, I just mean in terms of looking across large numbers of individuals and being able to do all kinds of discovery because you have large-scale data across those individuals. And that is all very important. And the use of the term small data is not to be snarky, not meant to be snarky. It's really just meant to be a complementary perspective, which is to say there's also a lot that's important and relevant if you look at many sources of data about an individual over time. And that because we live in a world where we generate so much digital data as individuals, as I'll be saying more, there's a lot of interesting work to do in this sort of small data science side as well as the big data side. Not instead of, but very much complementary to. And so what we want to introduce is to pursue that idea of how can we think about, from the patient, consumer, individual perspective, addressing health from prevention to treatment and disease management. So I like to think about this in this context of these, if you will, these feedback loops of health. I'm an engineer, a technologist, so I think about things this way, where that as an individual, the data about me, that n equals me, that n of 1 data, is informing and increasingly, we hope, will inform these 3 feedback loops of care. One, and the one that we typically think of in clinical care, is the one for the clinician. So is this patient responding to this new care plan? Is this the right medication? Is this the right dose of this medication? Is this the right post-surgical physical therapy? Whole range of things, right? You send somebody home with instructions and prescriptions and such, and they come in and are checked in different clinical settings, whether it's blood work that you do to check for side effects, or whether it's actually checking some clinical parameters to see if they're responding and if the drug is effective. Of also great importance is this, for the patient themselves, is this new medication working for me? Or this new approach working for me? So for the most part, many patients don't think of this as a context in which they are the innovators or the decision makers. They bring home a prescription and take a drug as prescribed and then stop taking that drug as prescribed. But most people, unless you're a member of a sort of a rare population of quantified selfers, are not really doing a lot of self-experimentation. But when it comes to things that people buy from GNC or Whole Foods, whether it's ginkgo biloba or supplements or what have you, or deciding that you're gluten intolerant or not, people do, when it comes to health and how they feel and their well-being, do go through a process of, is a new regimen working well for me or not? And many of us form what we don't even think of as theories, but we think of as facts about ourselves, right? Whether you're sensitive to, tomatoes or red peppers or something else doesn't agree with you. Whether acupuncture works for you or whether you go to a chiropractor. Or if you're given a medication that says take as needed, whether you're taking medication for migraines or for lower back pain. And then finally, as these data streams can also help to inform, as we get much more data of what people are doing outside the clinical setting, and if we capture that data in a systematic way, and we have systematic ways of representing it, and we bring that data together, we can start to have evidence around things around which now we just don't have evidence, right? So I remember early on in starting to, in this healthcare context, asking a dermatologist at UCLA at the time, first of all, whether, as the teens thought, that chocolate caused them to break out, affected their acne. And if it did, how long did it take? What was the delay between something you ingested and breaking out with acne? And the response from a very reputable set of dermatologists was, we don't really know. There's no evidence around any of this, and we don't even know what the delay is. Now, it's not a life-threatening problem, but there are just many things that haven't been important enough to necessarily generate the evidence relative to the cost of generating it. And now I think if we want to leave you with one thing, it's that the cost of generating this sort of evidence is really, really, really low, because of everybody in the room who raised their hand when I either asked for Android or iPhone. And so because that incremental cost of generating systematic data, it takes some discipline on our part in deciding what the data should mean and how we should encode it and how we should protect it and how we should share it. But we don't have to get people to buy new devices or do much more than perhaps download an app or two. So when we talk about these data streams, we're talking about many sorts of things, all of which are not in the future, but very much present. So perhaps if you get one access, it's still the case that if you can choose one data stream to give you the most information, it would probably be that continuous activity location trace that if you run moves or a number of other applications, just runs in the background on your smartphone. And it gives you, once you download it and enable it, you never have to touch it again, it generates a continuous 24/7, 365 information about when you're ambulatory, when you're sedentary, many cases the pace at which you're walking, and where you are at what time. So what time you leave the house in the morning, when you're getting to work, how many hours you spend out of the day. And these things can, on the one hand, cause you to have privacy concerns, but on the other hand, if you think about what's a representation of how is somebody functioning, whether they have Crohn's disease or rheumatoid arthritis or lower back pain or depression or migraines, these are all things that as people are doing better or worse can show up in these diurnal patterns. Second, mobile apps and usage of those mobile apps, whether it's what people are planning, who they're communicating with, or where and when they're playing games and their performance in those sorts of games. Digital traces that start to extend beyond the phone that are just from other things we do. So all the different forms of binging that we now can do, whether it's Netflix binging or seamless binging. We have so much just readily available to us, and they have an influence on our health and are sometimes a indicator of our state of mind. And then, of course, yes, there are real sensors. I think down the hall or in another room, they're talking about the role of hardware in this space. And I'm wearing a smartwatch that talks to my phone. I wear a watch anyway, so it might as well give me some other messages. The other sensors on it are not particularly good or particularly interesting, and it's largely redundant in the data it gives me currently with my phone. But wearables are getting better, and they're important. But in my opinion, they're not more important than all the other digital traces that we already currently generate, and with a little bit of analysis on top of them, what we can infer from them. And then finally, while we tend to think of self-report as old school, right, standardized instruments often in clinical terminology mean a set of standardized questions for an individual, how somebody reports and how they perceive they feel is still relevant. Not everything is automatically inferable, and even if you can automatically measure something, how somebody perceives it is still quite important. And so to talk more about that and the novel ways that our mobile devices are letting us pursue even that old school self-report, I'm going to hand it over to JP.
Right, so on the one hand, you have this school of thought that the self-report is in fact old school, that it's a dirty word in a lot of circles. And on the other hand, you have this group of people who are doing the EMA research who, self-report is sort of this savior, right? More data all the time, great frequency. But as Deborah pointed out, there's all sorts of other ways that we can get the majority of those data. Not quite all of them, but the majority of them. And a lot of the work that I do is focusing on those last few areas where it's difficult for one reason or another to be able to get at that data through passive methods. So what's shown up here is an example of one such tool that we've developed. The idea behind this was that we wanted to replace forms like PANAS, right? The sort of gold standard 20-item measure of affect, right? That's so important in lots of different people's work. But it takes even that, sort of 20 items, just go through and list off numbers. It still takes a little while, and you can really only do it so often. Even though, we do think that affect probably correlates with lots of different other kinds of momentary things that we're interested in. So we sort of went through this process of, okay, how do we narrow this down? How do we make it a really small and quick tool to do these kinds of assessments? We experimented with lots of things, colors, sounds, just writing words, drawing pictures, all sorts of things. And they were all sort of, somewhere on this spectrum of either, sort of too frivolous, too ambiguous, to being sort of too precise, and it didn't really let people express how they felt. So we sort of settled on this idea of images, and we went through this long and kind of extensive validation process where we sourced a bunch of images from Flickr, the Creative Commons Flickr dataset, where the images there had been tagged by people in the community with these key emotion words, 36 key emotion words that had come out of the literature. And then once we had those, we sort of subjected them to lots of people and got these subjects to tell us how they felt at that moment, and then choose from this set of pictures which ones represented that feeling that they were currently experiencing. We did that kind of iteratively until we got down to this sort of final set of 48 or so images that randomly get selected to draw on the screen. And then just by sort of opening your phone, you get prompted, you tap one of these images. We can then correlate your response with, depending on sort of demographics, which gold standard assessment you want to compare it to, with between sort of a 0.75 and a 0.9 correlation to these gold standard measures. So we've taken 20 items and boiled it down to something that you can do in just a few seconds on your phone, and it even looks kind of cool. So here's another example of this. So this is work in progress that has not gone through this sort of lengthy validation process yet, but it came out of some work that we're doing where we're looking at different ways of assessing pain and function in chronic pain patients and in patients with flare-based conditions. And so the idea was, we can get people to self-report their pain. This is gold standard, it's important, but there are some issues related with that. We can give people these sort of, gold standard, old school forms to fill out that goes through and details all of their activities of daily living, right? Which is this great proxy for the pain that you're experiencing. How is it interfering with your daily life? So, these forms, they're long lists of activities. Some of them even come with illustrations that were created in the 1950s. No one can relate to them. When you look at this form, about 90% of the activities on there don't pertain to you in your daily life at all, but you still have to go through and, sort of check, yes, I don't have problems with this one, I don't have problems with this one. So, how can we make that better? The first thing we thought was, all right, let's just replace everything with images. Even that in and of itself would be better. But, this is your smartphone. It knows a lot about you. It's a tool that you might be able to use over time. So we thought there's got to be a way that we can make this better and more personalized for you. So what we have is this system, YODL, Your Activities of Daily Living, which has kind of two levels assessment. The first is what we're calling the monthly level, or the monthly identification. And this point, the point of this one is it is in fact the replacement of that long form ADL form, right? You sort of look at this large group of images visually representing all of the kinds of activities that you might be doing in your daily life. And you find the ones that are hard for you or moderately hard for you when you're experiencing pain or when you're having a bad day, and you check that one off as hard or moderate, right? So that, in a sense, we haven't validated this stuff, but our hypothesis is that that could replace some of these longer form ADL forms. And then much quicker, we have very small amount of evidence with people suggesting that this is in fact quicker, easier to get through than these long forms. But the real advantage of this is then what we have is a smaller subset of the few activities that are in fact difficult for you when you're having a bad day. And so what can we do with that is we can send out a prompt for you, on specific days, whether it's when we know that you're experiencing pain, or whether it's on a nightly basis, or whatever it might be, depending on the kind of research or practice that we're doing, to prompt you to just say, okay, here's your set of maybe 9 images or 5 images that you found were difficult on a bad day out of that whole big subset, and just check the ones that are actually difficult for you today, right? So we've essentially been able to take this, long form ADLs, which you have to do once every couple of months, fill it out in the office. It's based on recall, and we can do this quick daily assessment, which we're hoping will be able to give us that the data in between those long form assessments at your visits. Okay, so moving on to talk about a little bit more about the data that comes out of these small data streams and these systems that we've developed and lots of other great people have developed. So you have to look at it in terms of it's called a food chain here, but there's this sort of hierarchy of the way the data comes out of streams and the way we're actually able to interact with them, right? So on the very bottom of this food chain are the raw measurements, right? Now for the vast majority of people, and certainly for busy clinicians, the data that come out of these sensors themselves are completely useless, right? Accelerometry data is useless. Isolated locations that you may or may not need to stick on a map, those are more or less useless. The aggregate of these data, even if you don't have intelligent ways to look at it, it's meaningless for most people. So what we need to do is be able to bring that up a level and turn them into features that are actually meaningful, right? So you can see some of these here. We're basically picking out the raw data and we're trying to infer the things that are important. In this example, there's some identifiers for movement, hours out at home per day. These are just sort of summary level statistics for the metrics that have come out of this raw data. Then the next level up is where things really start to get interesting. It's okay, how do all of those different fused data or summarized data actually map to aspects of our existence, right? Whether it's our behavior, our symptoms, our state. Can we in fact go in and pick out from these data, from these summarized data, markers for for patient function or any of these things? We're calling these behavioral biomarkers, right? So I'll talk through a quick example of one. This is one that we've been working on developing a little while now, particularly in the context of chronic pain. So we're trying to develop what we're calling a mobility index. The idea here is that the data that comes out of whether it's our phone-based sensors or your Fitbits, it's an interesting summary for people to look at. It's not really that actionable from the clinical perspective, right? In the practice, your patient comes in, shows you their Fitbit data. That in and of itself is not that useful. It's still vastly more useful than what the accelerometer would give you, but it's still not that great, right? So we've tried, you see these summaries here. This is from an app that we have called Mobility, which we'll talk about a little bit later, free sort of open source software. And we've chosen to summarize things in terms of minutes active, the longest trek, which is sort of like your longest stint, either walking, exercising, the number of hours that you've spent out of the house, and we have a few different other metrics. Then the next step is, okay, how do we summarize this back to the clinician in a way that's meaningful for them and they can make decisions on? And after doing a sort of a participatory design process with several clinicians, we settled on what we sort of term the calendar view. It's a very familiar construct for people. You're used to looking at things in terms of calendars. The clinicians that we interviewed, particularly around flare-based and chronic conditions, they're used to talking to their patients in terms of the last couple of weeks, the last couple of months. So being able to summarize these data into a calendar view was a big step. So the next level up from that is when we get to the point of actually, sort of linking these measurements up with with clinical outcomes, whether it's behavioral or flares or whatever it might be, and sort of fuse them into one index, right? So even this, we've got several different data points represented on the screen. You're a busy clinician. You just want to see one indice that you can compare to previous version or previous visits from that patient and see sort of trends on the upside, trends on the downside. Okay, now we'll transition a little bit, start talking about how we can use small data to do lots of different things in care or in behavioral intervention and so on. The first area that I'm going to talk about as an example is just a way that we can use small data for something that we call social facilitation. So this is basically, we're giving people tools to help other people be healthier or to help people be healthier in a social kind of context, right? That's taking advantage of this idea that when we do things socially, our peers might have a very positive or negative influence on us. We might find role models in a crowd and aspire to do more things like them. So we might have friends who are able to influence greater influence on us than our Fitbit in and of itself might be able to do, and certainly more than our clinician can do when they tell us that we need to go home and do our exercises. So this is a big deal right now. This idea of getting sort of your peers to do things with you. It has been for a long time when you look at things, systems like Weight Watchers, experiments going back to Ash in the 50s. But now with technology, we're actually able to facilitate doing this at much bigger scale, right? And so when you look at groups like Rock Health and some of the other health-based accelerators and lots of startups coming out nowadays, there's this real trend towards scaling the influence of sort of one or many knowledgeable coaches, or whether it's nutritionists or nurses or just sort of general health coaches, right? So it's the idea of how can we take technology, provide the coaches with enough data, right, from these small data streams with which to make fast-acting decisions about all of the people in a certain cohort that they're in charge of, and be able to quickly disperse out to those individuals different kinds of ideas, messages of encouragement, sort of helping them work out with their schedule. Maybe the problem is that this isn't the best time for you to be exercising, and if we can adjust your schedule a little bit, we might be able to get you to do this, and so on. So the first example that I'm going to talk about, and then I'll turn it back over to Deborah, is one that doesn't involve coaching so much as it does these other aspects of social facilitation. So you might have seen on the first slide that I'm also the co-founder and CTO of a company called Wellcoin. So the premise of Wellcoin is basically that you earn these Wellcoins for any healthy activity that you do, sort of a very broad and encompassing view of health, everything from sort of mental to well-being, to the real health metrics that most of the people in this room are a little bit more interested in. And sort of the more validation that you have for any of these activities that you do, the more Wellcoins you earn. So you just go in and say, I took a nap for 20 minutes. Well, that's a tiny bit of Wellcoins. If you take a photo of your healthy lunch and post that, and then 2 members of our community vote on it anonymously, that gives you even more Wellcoins. You connect to your Fitbit, or you shop at Instacart or Fresh Direct, and we get your receipt and evaluate it. Those things give you the most possible Wellcoins. Then you spend those on rewards. So all of that part is that sort of classic reward behavior. There's all of that. But one of the things that we've found is that we have this sort of internal saying that people are coming for the rewards, but they're actually staying for the social motivation. We took this kind of bet that if we put in a Facebook-like newsfeed or a Twitter-like newsfeed, that we actually might be a place where people would want to come and talk about their healthy behavior with peers or like-minded folks, right? And when you see that stuff on Facebook and Twitter, you unfollow, right? That's the last thing you want to see in your newsfeed. But when you have a place where you go specifically to do that, it turns out that it's really powerful. And so we have lots of evidence so far of healthy behavior spreading throughout networks. We have lots of evidence of sort of healthy recipes being used by one person and propagating throughout the network. And we have lots of evidence of people sort of increasing their healthy behavior over time who are more participatory in these networks.
So just before moving on to this, something I wanted to emphasize is that with small data, what we're describing is not particularly difficult. It doesn't have to start with a lot of discovery. In fact, the place to start with small data is with what clinicians already know they would like to be able to measure. Not with new measures that they don't know about, not with new genomic markers that we don't yet know about, not with new evidence from the microbiome that we don't yet know about, but in fact with the things that the rheumatologist already asks their RA patient when they're looking at some early indicator of a flare, or they're looking for how they're recovering, or what the orthopedist already asked, or physiatrist already asked their lower back patient about how much pain they're in as they reach over to touch their toes. And so we can take what are existing clinical observations, even the pegboard test that was one of the depictions in one of those slides with somebody, for somebody with Parkinson's, or the 6-minute walk. We can take these existing measures, and now we have the opportunity for doing equivalent proxy estimated measures and getting those kinds of samples on a daily, even many times a day basis, because we can do estimations of those things based on these measures. So we took this idea, the same idea of small data, to something that's very important to health. It's upstream of many health-related issues, which is food. And so you take that same idea that JP was just talking about, of social facilitation. And in this case, we developed a system we called Pushcart. And for people who are doing online grocery shopping, you always get back a receipt in email with an itemized list of your purchases. So we just took that idea, and when you sign up for Pushcart, we automatically get your email receipts with your agreement. We automatically get those. The software parses them and uses nutritional APIs to create nutritional summaries of what you purchased. And then the idea is that a coach or a nutritionist or a Wellcoin peer can look at your latest purchases and make swapping suggestions. The strawberries for strawberry ice cream, for example. Okay. And what's interesting about it is that they can also see what of these suggestions actually get executed. And you can see when those suggestions stop being executed, because as we all know, we try to form better habits, and when we sometimes succeed, we also have the issue of life happens and throws us off track, and we sometimes fall back to our previous, perhaps poorer habits. So this is another system that's open source, prototyped. We're actually looking for people who are interested in trying it out in different contexts. It has the narrowness of being about people who currently do online grocery shopping, because we don't get email receipts from our bricks and mortar grocery shopping. But it's an interesting example of using small data, because nobody has to report anything. Nobody has to take pictures of their food. They don't have to keep food journals. It's not attempting to record everything you ingest, but it's looking at the food environment you're creating at home. We can also, by the way, the system can ingest your seamless receipts as well. Another example of this, which is a pilot that we're building towards and doing with Dr. Vijay Vaughn at HSS in 2016, is around lower back pain. And so again, we're pulling together the ideas of small data and trying to get inside of this behavioral loop. Many people, herniated disc, a very prevalent problem that can have many outcomes. One of those outcomes can be going for surgery that has mixed results. Another outcome can be being in quite a bit of pain and at lower function. And another outcome for some patients is an increasing dependence on opioid-based pain medication. And in many cases, lower back pain is something that's treated by your primary care physician, and there really aren't many alternatives to that, coping with your pain through medication. Now, there is evidence that other things work. So Vijay Vaughn, for example, physiatrist, has specific sets of lower back pain exercises that you do either on a daily basis or several times a week for about 15 minutes a time, as well as regular walking. And he has evidence-based good results that for significant numbers of patients, this really produces higher function, more pain-free quality of life. The problem is habituating to doing those exercises. That 15 minutes that sounds, well, of course I'll do it, is as expendable and delayable as it should be easy to adopt. And that is his biggest friction in actually getting this to help more people. So we're using the idea of social facilitation and small data. So we ask coaches who currently talk to patients and try to help them through this. We are going to do video delivery with a startup called Force Therapeutics that does video delivery of those several times a week exercises, and analytics are captured on when the person ran those videos, when they snoozed them and wait. We have that self-report YODL for the more frequently reportable self-report around pain. We have the passive data gathering of how much people are walking each day. And we're creating a dashboard for that coach now so that they don't only have to reach out and ask the person how they're doing. They can see how all their clients are doing. They can see who is struggling to establish the habit, maybe needs a little messaging coaching to try to find that time where the person would be able to execute on it, not aspire to do it in the morning when in fact getting the kids off to school just repeatedly interferes. And so that social facilitation is informed by this small data. Now, in the long term, will this all be automated? Maybe. But the scalability of using high tech and these personal data streams processed in a way that they're easily summarized, by letting that high tech let the person with high touch be able to deal with many, many people in a scalable way and in a personalized way, that's where, not just we, that's sort of where there's a lot of, that's the sweet spot right now. That it's not so much just this personal data trying to tell that person directly what to do. It's hard to deliver the right kind of message and figure out what's going to work for that person and why the last messaging didn't work. People, particularly people who have had some training as health coaches, community health workers, or nurses, are good at that. But it's time consuming, and for them to elicit the information they need to do it really well. And so that's that spot that we really think is the sweet spot for small data and the sweet spot for getting around the fact that people were very excited about Fitbits, but then the news and the tweets and everything about Fitbits shifted to they stopped being used after 3 months or 6 months. Wrong clicker. Okay, so before we move into this session where we'd like you to be thinking a little bit about what you might do with some of this technology, I want to end by sort of addressing this question of if all the devices are out there and it's only a matter of a software download and it's not even a matter of really having to do discovery because we can already know what the proxies will be for many existing clinical measures, why don't we have more evidence? Well, I think that in some ways, in both the marketplace and our academic processes have underperformed. And we really haven't done the kind of rapid iteration community work that we've seen in other contexts. I'm biased. My background is in internet protocol development. And really, the whole reason we're here at all and talking about any of these technologies is because the internet developed and evolved not in a siloed way, but in fact in a very much communal, modular way. So there was a lot of continuous improvement going on in all aspects of the internet simultaneously, and a lot of building one thing on another. And there's now some real movement in that direction. So how many of you heard of ResearchKit? Great. And so ResearchKit was an announcement earlier this year by Apple and Sage BioNetworks. And it is a system, let me just skip right to that now. It is a system that gives you a software framework so that you don't have to go out and have an idea for an app and then go contract a software developer and get some specific app done in an idiosyncratic way. ResearchKit is a software framework that says, look, many of these uses of mobile health data have similar components. And if we build the framework that let people, and it's open source as a framework, it will float all the boats higher and make it much easier to build good apps. It is easy to build not good apps. It's easy and almost too cheap and too easy to build not good apps. Thus, we have this proliferation of apps in the App Store and the Play Store. ResearchKit says, let's standardize what these look like, and let's try to encourage people in the community to share the modules they create. One of the most interesting things about ResearchKit that I really suggest you look at afterwards is their consent process. They went and created a modern consent process, easy to understand, with sort of visual components to it. Really excellent. And if you use nothing else from ResearchKit, using their consent process, I highly recommend. But beyond that, they talk about standardizing a self-report component, as well as standardizing passive measures and prompted sensor-based measures. One of the most interesting of the ResearchKit applications is the one for Parkinson's. Interesting from a technical point of view, at least, because it involves both the walking ambulation, but also as a tapping test, and uses the touch screen and that sensory input to capture tapping test. Another really important point here is that makes mobile health and small data easier, and therefore we should get going with it already, is that initially you can use it to look for in-person changes. We don't have to start using something as a diagnostic. We don't need to start by saying, put something on the phone that will try to diagnose that somebody has developed Parkinson's. That is not the place to start. Too hard, right? Start with people who are being treated for Parkinson's. You're trying to titrate their medication. You're trying to optimize their dosage. You're trying to do research, looking at how some combined therapy is good for managing their Parkinson's. And for them, you can see changes in their tapping behavior from one test to another. And looking for a change within subject is a much easier initial challenge than finding that measure that's going to detect it in somebody and be used for diagnosis. So in general, in thinking about this and thinking about small data in these mobile health applications, it's in doing it for measurement of treatments, management, encouraging prevention, rather than initially thinking about this as for diagnosis. Eventually, some of this will have play in diagnosis, but that becomes a big data a problem again, and one for which we should do the small data and get the utility out of the small data. And yes, over time, the research will be served. And so Bridge is something from Sage Bionetworks that they established, which was to try to build into ResearchKit applications that people would share at least somewhat acceptably de-identified data with the research community. It's not a Trojan horse, because it's not a secret, but they really tried to say, we want to encourage researchers to be sharing more of this data that they're going to get through this process. And so if you opt into Bridge, it gives you, without additional work, your data that you're collecting for your research study can be shared with the larger research community, which will allow that big data side of things and for the algorithms we use to get better and better, and for the research studies to contribute to one another faster. I'm happy to say that for those of you who said you had Androids in the audience, I'm one of them. New York is a very unusual city in terms of its the prevalence of iOS devices. In most of the rest of the country, let alone the world, most people can't, just out of discretionary income, afford a twice as expensive device. And Androids come in a much more flexible price range. And so we are building a version of what we're calling Research Droid, which will allow you to build your research study that can be deployed for both iOS and Android users. Because obviously, while there was a time back decades ago when maybe you could do, you could do a cardiac health study only on men, right? We did away with that. And while this isn't necessarily the same level of importance of an issue, we shouldn't be doing our research only on iOS users and not Android users, particularly given the demographics that are typical of those two devices. I, of course, can't fail to mention that we also have this, while ResearchKit and Bridge let you have a more modular way of building these apps, we also want these data to be interpretable in consistent ways and substitutable one for another. Some people have Fitbit giving their activity traces, and some people have software running on their mobile phone. Some people are going to develop a measure of stress coming out of your voice samples during speech, or the work that's being done in Parkinson's, again, to pull off indicators from your vocalizations, and coming up with standard measures, again, not the raw data, but those behavioral biomarkers. We want to have standard ways of representing that data so that these data can be brought together, substituted for one another, and even integrated eventually into EHR workflows. I'll skip this just to say that if you're interested in this space, we have a bunch of open source platforms, and we're happy to share and help people get started exploring in the space. But for these last maybe the next 10, 12 minutes, and then we'll come back and talk a little bit. JP, did you want to kick off this?
Yeah, sure. So as Deborah mentioned, we thought this might be a little bit more workshop-y, breakout session-y in nature, different backgrounds, different expectations. So we decided to come up with an activity for you all to try based on everything that you've learned in the last 37, however many minutes. And the idea is really around, okay, there's all these small data streams, there's all these ways that you can address patients and collect data. What can you do with them, right? So what we want you to do is design your ResearchKit or Research Droid study. So it's best if you get in at least a group of 2, probably no more than 4, I'd say, for being able to do things well. And what we're looking to do is, sort of identify a problem and a solution that you're after, right? So who are the patients or individuals? It doesn't necessarily have to be patients. What do you want to know? So what data do you need to collect from them? And what do you want to measure, right? So once you've sort of established that, so right, it's your problem, it's X condition or Y behavioral issue that you want to address, start to think about then how you might get at those data. So specifically, which tools and methods are you going to use when you're doing this? So you need to get really specific here and kind of link up the ideas that you had for what you wanted to know and how you wanted to measure them with the specifics of it, right? So what survey tools are you going to use? These are maybe the longer form stuff or even the daily EMA type measures. What kind of prompted assessment might you use? So these might be tap tests, a get up and go test, anything along those lines that can be delivered through the phone. And last, what's the set of passive data that you plan to capture and sense, either with the phone or, I suppose if you need a wearable and it's cheap and exists already, go for it.
And the idea is don't overthink it, right? So Facebook is one of the companies that I think of that started the whole thing of recruiting their employees through 24-hour hackathons. So you can't have a thought, you couldn't at that time get a job at Facebook if your ideas couldn't be thought of and implemented in 24 hours. So we just want you to talk this through, come up with an idea around some condition, take 10 minutes.